Good afternoon, everyone. At the outset, let me thank Shyam for inviting me to this meeting and everyone guys. And also thanks to everyone who is here after such a sumptuous lunch and still looking at the academic meetings that we're having. So let me start talking about the hereditary breast cancer, which is something which everyone talks about today, and it's really coming up in the big way in India too. And I'll be basically limiting myself to the role of risk reduction surgery. I will not be talking about a lot of the medical parts and other things on this. So let me first pay homage to the father of cancer genetics, Henry Lynch, who was the first person who described these cancer genetic syndromes in the 60s and 70s. And as Gita said, hereditary cancer would be incomplete if you don't mention and thank the beautiful lady who has actually made it more famous than actually doctors would want it to be. And people come out asking for mastectomies after this. But yes, it has really put hereditary breast cancer on the map of people's mind. So, when you talk about hereditary breast cancer, we're talking about hereditary cancer syndromes, most of the cases. And these occur when an individual is inheriting the genetic mutations by virtue of the germline mutations. So what's the difference? A germline mutation would be one where the mutations are passed from parents to offspring. Vis-a-vis somatic mutations, which are acquired by any cell in the body after birth. See, all cancers, sporadic cancers, are actually having somatic mutations, but they're not passed, and therefore they will not be concern for us when we talk about hereditary breast cancer. The gene discovery started in 79 when P53 was discovered, and we had the BRCAs discovered between 90 to 95. Apart from that, the other strong penetrant genes like ATM, PAL-B2, CHEK2 were also discovered. So most of the genes which are associated with hereditary breast cancers were discovered in 2005. After the genomic project, so many more have been discovered, but BRCA1 and BRCA2 still are the most important. So when we talk about hereditary breast cancer genes, the division is into high penetrant genes, which would mean that they have a 5 to 20-fold chance of a patient developing cancer. Vis-a-vis moderate to low penetrant genes, which have 1.5 to a 5-fold chance of getting cancer. And this is the same chance that a lobular carcinoma or atypical hyperplasia would have. So what to do with that is still we do not know. For the high penetrant genes, definitely some sort of thing has to be done. So the high penetrant genes are the BRCA1, the BRCA2, the PAL-B2, P53, P10, and STK. These have almost a 50 to 85% chance of the patient getting cancer in the future. And then we have the plethora of low penetrant genes, and I will not go into detail of that. Suffice to say, we today need to understand which patient would require these genetic risk evaluation. And I talk about a person who comes with cancer. So any person with cancer with a known mutation in the family, diagnosed breast cancer less than 50 years of age, triple negative at or before less than 60 years of age, 2 breast cancer primaries, breast cancer at any age but with one close relative, 2 or more blood relatives, person history of pancreatic cancer at any age, any individual with acne Jewish, which I don't think it's important for us, any male breast cancer in the family, or any individual, the personal family history of 3 or more of the following, diagnosed before the age of 50 years, the breast cancer, pancreatic cancer, prostate cancer, melanoma, sarcoma, adrenocortical carcinoma, brain tumors, leukemia, and the hereditary gastric cancer, colon cancer, endometrial cancer, thyroid cancer, kidney cancer. So any of them, 3 of them have been there in the family. These are the patients where genetic risk counseling and evaluation is important. I will limit my talk to BRCA1 and BRCA2 because these are the most commonly talked about hereditary genes. And basically what we talk about them holds true for the other strong penetrant genes also. So even though I'm talking for that, you can actually extrapolate it to the other genes. The main understanding of the importance of these 2 genes came by the Embrace study, which is a prospective analysis. And what it told us For the BRCA1 carrier, 60% risk of breast cancer, 59% for ovarian cancer, 83% for other breast cancer. The BRCA2 has 55% for breast cancer, 16.5% ovarian cancer, and 62% for controlled breast cancer. Understanding another thing, that hereditary breast cancer is only around 5 to 10% of breast cancer cases, but majority of these cases have a gender mutations in BRCA1 and BRCA2. And the problem is that a surgical treatment in this patient is a little bit tricky because these are young patients and the challenges involve aggressive therapeutic and risk reduction interventions. So if you have a BRCA patient with LFBC, our basic focus should be on the disease because that might outweigh the risk of a secondary cancer. On the other hand, if it's early breast cancer and BRCA and BRCA2, even then we cannot just have a blanket statement because the age, the completion of the family, and the psychosocial concerns of having a risk reduction procedure done are still to be looked at, and only then we take a call as how and what to do. So I would say that if today a patient diagnosed with breast cancer without having a BRCA, what surgery would be suggested? I think any of this or all of this could at some point of time be thought of as right. On the other hand, if it is a patient with a BRCA mutation, we might talk about this, but something that is always added is this, and I think today we'll look at it. This is often the most commonly opted for disease or procedure in a patient with a BRCA positive disease. So what are the important factors that we need to look at when we talk about BRCA positive disease? What are the chances of local recurrence in the same breast? What is the risk of control-lateral breast cancer? What is the effect of prophylactic or the risk reduction mastectomy on survival? And what are the factors that will increase or decrease the risk of breast cancer on the same or the opposite breast? I had a recent patient, and I think most of Geet has also seen this patient. This patient was a young female, 40-year female. She had lump in right breast for 1 month. PET scan showed mass T1 with bilateral ovarian masses and internal lymph nodes, and even external lymph nodes. We did the histopathology of the breast, which was IDC, TNPC. C1 was normal, CA was raised. We thought it might be a Kuchenberg, but since the whole process changed, we did a biopsy and it was adnexal carcinoma. This patient had 2 cancers. Since it was also TNBC and she also had some disease and we were waiting for the BRCA report, we gave her 4 cycles of NACT, doxy with carb. BRCA was positive, BRCA 1 was positive, BRCA 2 was negative. I did a right MRM with sentinel sampling with a controlled risk of mastectomy and cytoreductive surgery. The final histopathology was there was no residual tumor in the breast, and the ovary had adenocarcinoma on the right side. There was a nodule in the pelvic peritoneum which was positive, and also in the pouch of ductless and vasorectal nodules were positive, though nodes of mental and peritoneum were completely negative. I sent the patient for 2 more cycles of chemotherapy. The issue is, with the current understanding, could I have done differently? Could something else have been done which actually might have been better at a young age? And let us look at the option that we have in a BRCA positive patient. Assuming the eligibility for a BCS, we could have BCS versus MRM, a nipple sparing mastectomy versus the MRM, a contralateral risk reduction mastectomy without an NSM, and a risk reduction hysterectomy. These are the 4 surgeries, the risk reduction surgeries that we often talk about. So the issue becomes, is a BCS safe in the BRCA cancer? And there have been multiple studies. If you look at Nielsen, Pierce, Debrock, what these 2 studies showed that the local recurrence was definitely higher if we do a BCS vis-a-vis mastectomy, though Brock did not show that sort of difference. And the basic difference that was shown was in early time, within the first 7 years, the recurrence difference was 17% BRCA, 11% without BRCA, which was not significant. But after 7 years, this recurrence rate started increasing. And the thing was, is it a recurrence or second primary? And what was studied was that only in 30% it was true recurrence. In 70%, the histology was different quadrant, and they were actually a different primary. And in all of these patients, survival did not change. So if you look at the overall survival, BCS versus mastectomy, it is similar. The recurrence as the time goes by definitely is much higher with the BCS. And for this reason, since the survival is same, BCS should be offered as an option to BRCA mutation carrier with proper preoperative counseling if the patient so desires. Though ipsilateral mastectomy should always be discussed to decrease the chance of a local recurrence. And if you use a breast conservation surgery in this procedure, local recurrence rate should be tried to be reduced, and it has been seen in multiple studies that adjuvant chemotherapy and a bilateral circumflexotomy reduces the local recurrence to 50% in the same patient. So if you are giving the patient opts for a breast conservation, she should definitely undergo this. Now, in the caveat for the other strong penetrance genes like TP53, this is one area where BCS is not indicated because a TP53 patient predisposes radiation to DNA damage. It has been seen that if a patient of TP53 is given radiation, there is high incidence of angiosarcomas. So a BCS is okay for BRCA or BRCA2, but for the other strong penetrance genes, we don't have data to suffice that we should get away without a mastectomy. The other thing is, what about nipple sparing mastectomy? Can we do that? Because if we can do that, the cosmesis improves. And we had studies from Manning and Zhao, and both of them showed that there was hardly any increased recurrence in these patients. And actually speaking, if we do a nipple sparing mastectomy, the cosmesis was much better as compared to any other patient. So recurrence rate was not too much, almost similar to mastectomy. So today, if the patient wishes, I think we should all be offering a nipple sparing mastectomy. Of course, we have to have the proper plastic surgery tools or education for that. The other option becomes, what about the controlled breast cancer risk? And do we do a controlled risk reduction mastectomy? Now, what is interesting is that in a BRCA1 patient, this is a BRCA1, I think my photo is coming over that. If you have a patient who is less than 40 years of age, after 20-25 years, there's 60% cumulative risk. And if a patient is more than 50 years, even then the risk is more than 38-40%. On the other hand, if it's a BRCA2 patient, in that scenario, less than 40 years after age of 25 years, the risk is around 68%. But for a patient who was diagnosed after 50 years of age, the risk after 20-25 years is only 20%. So in a CRSF, it is important to understand what is the age of the patient and whether it's BRCA1 or BRCA2 before we opt for a controlled risk reduction mastectomy. The risk of recurrence on the opposite breast definitely is there if you don't do a mastectomy, and that risk has come down with most of the studies that has been shown, Kaas et al., one Sprundle. What is important is that 3 or 4 important studies by Evans, by Hemskirk, by Metcalfe and Sprundle. These 3 studies actually show that survival is also better vis-a-vis not doing a CR. And Sprundle, those showed that the survival did not change. So we had a mixed breed where few studies showed that survival was better, but then this was a prospective cohort study. We didn't follow up 4 years of Hemskirk and Gerritsen. The mortality rate was 9.6% of the group with a controlled mastectomy, while it was 21.6% with this group. So he definitely said that we should go ahead, not just for the purpose of removing the risk of local recurrence, but for survival. The Mithal Carbine et al. Of 7 studies did not show any survival. So the jury is still out for that, whether the survival is different or not, but definitely the chances of second primary goes down, and we should definitely offer CRNN with or without NSM in all patients with BRCA1 and BRCA2 mutations. This is the last part of the recent surgeries, and again we have plethora of studies working on RRSO. What is important on these studies, which are most of the prospective studies, and they show that if it is a BRCA1 patient, and we're talking about the breast cancer risk, in a BRCA1 patient, the hazard ratio is beyond 9/1. That is, a BRCA1 patient, RRSO did not have any benefit in terms of decreasing the breast cancer. On the other hand, BRCA2 one, after 5 years, did show. If it was less than 5 years or 2 years, there was hardly any benefit of a risk reduction has removed it. With BRCA2 also, but as the time progressed, there was a benefit. So, what is important to understand is that in a BRCA1, we might not opt for NARA-RSO, but there is a potentially beneficial effect in the BRCA2 mutations, and this could be because that most of the BRCA1 are TNBC triple negative, while BRCA2 are more often than not CRPR positive. And there was there was a very small incidence of increased survival, so there is a very low set evidence that it might improve survival. But what is important and why RRS should be offered, that it has reduced the risk of ovarian cancer to 80%, and all-cause mortality by 68% in females with BRCA1. So the reason that we have to do RRS is not for the breast survival, but to reduce survival, to improve survival, because the ovary is something which is bad, and because it is for the ovary, the timing of the RRS changes. For a BRCA1, it's 35 to 40 years, while for a BRCA2, it's 40 to 45. Understanding that if we do it early, the patient has problems like cardiovascular disease, osteoporosis, and quality of life. So RRS should be delayed, even though we are doing the CRSF or mastectomy much earlier. So last 2 slides. So what do we do as an approach? If the patient is having all these things, BRCA1 carriers should have their surveillance started at the age of 18 years, with MRI starting from 25 years, and medication, per se, like tamoxifen, should not be used in BRCA1 because they are negative, but in BRCA2 carriers, tamoxifen has a role in decreasing it. Mastectomy, risk reduction is important in BRCA1 because we do not have the option of a chemo prevention. But for a BRCA2, patient can be discussed about it. We can talk about medical agents to reduce the risk, or we can go for a mastectomy. And the breast cancer is male. There has been seen there is no benefit of a risk reduction mastectomy. So the male breast cancer, it is still not evaluated whether it's BRCA1 or not. So to conclude, risk reduction surgery is an important armamentarium for the hereditary breast cancer today. We can opt for mastectomy or nipple sparing mastectomy or BCS to site. Safety of BCS is basically for the risk of the second primary. This risk is also reduced using a central neoprectomy, tamoxifen, or adjuvant chemotherapy. Contralateral profile mastectomy reduces the incidence. Whether it has impact on survival is still out, jury is out, but yes, some studies have shown yes, some no. RRS current evidence of this carcinoma ovarian breast cancer in BRCA2. But whenever we are opting for that, we have to look at the psychosocial and infectious issues of the patient, especially when they are using RRSO. And based on that, this decision should be taken. Thank you very much.